probably one of the most important feature that can, if someone has a family history of sudden death, don't let him go home. Then of course history of cardiovascular disease, age itself, any psychiatric history. Like prodrome is also very important. Was there an aura? Was there blurring of vision? Generally people say कि मेरे कानों में आवाजें आना शुरू हो जाती हैं, शायद it's hyperperfusion, or your vision tends to become tunnel vision before you fall. So jerky movements, that can also happen. No symptoms. Okay. No symptoms generally also turns out to be vagal. Similarly, precipitating factors, just like as I've said, what was the activity? If you are exercising and you fall, it's more ominous. If you exercise and you are falling in the waiting period, that can be neurally mediated. Then triggers, emotion, fear, standing crowded environment, medications, post-exercise, as I've already told you, posture change. And posture change can be latent as well. You don't have to faint immediately. Even orthostasis can come a little later. So for risk stratification, you need to know the high risk features. I'm not going to the low risk features. So clinical history suggested of arrhythmia, palpitations, comorbidities like severe anemia or electrolyte imbalance. ECG can harbor long QT, short QT, Brugada syndrome, ARVD changes. All of WPW, they should not be missed. Q waves, because they tell you that this is coronary. Family history of sudden death, hypotension. If on presentation the blood pressure is less than 90, age. I was taught by my teacher that if the first episode is in the 6th decade, it's highly unlikely that it's vagal. And of course, cardiovascular disease, which can be structural or coronary. So this is the algorithm. So if you have a loss of consciousness, transient loss of consciousness, take a history, check for postural hypotension. 60% yield in the ER if you're checking an orthostatic blood pressure. If you're not, then you're missing a lot. Do the ECG, look whether it is normal, and do the labs in which echo is primed. So if there is a postural drop, orthostasis, treat accordingly. If it is neurally mediated, then do the head up tilt test, do a carotid sinus massage. If it is positive, do the education, tell the counter maneuvers, and if not, then it could be cardiogenic or it can be neurogenic. If it does not turn out to be neurogenic, then cardiogenic, go back up and work up the cardiac, take the history, look for high risk features, and then investigate accordingly. Now, if you see lower down on the algorithm, there are prolonged monitoring devices. Holter monitor, even when you do it for 72 hours, does not have a yield. If the syncope frequency is very frequent, then yes, but if it is not, then you need to think of prolonged monitoring. And implantable loop recorders, which are very expensive, have shown that if nothing comes through this algorithm, most patients will have either long sinus pauses or bradyarrhythmia. You can also do an EP study, but EP study does not have a good yield for bradyarrhythmias. And it's confusing if you find someone who has a bradyarrhythmia on the ECG as well as gets easily inducible ventricular rhythms. What do you do then? Should you put a pacemaker only or should you do more? Okay. So, evidence-based practice. And you see all the evidence is C, which is consensus statement. So coronary artery disease has hijacked most of the funds for things in cardiology. Syncope has poorly done studies with small numbers. So pre-syncope should be treated as syncope, and patients with high risk features should be admitted to the hospital for workup. They should not be sent home. Orthostatic blood pressure measurement, so you must do a postural check. Implantable loop recorders increase diagnostic yield and should be used where they can be, and they are cost effective in the long run, at least in Western societies. Patients with syncope who are at low risk of adverse outcomes can be sent home. And so electrocardiographic findings, maybe who do not have all these findings and ECG changes, can be sent home, low risk patients. So healthy adults with a diagnosis of syncope had higher rates in studies of all-cause mortality and recurrent syncope, cardiovascular events, and pacemaker or device implantations compared to their matched controls. So anyone who has syncope actually puts himself in a different category compared to the controls. And most of these patients were driven by cardiovascular, and most of these patients fell between 44 and 75 years of age. So clearly, whenever you have a syncope, it is associated with serious risks overall, but short-term mortality is low. The initial mortality is 0.7 at 10 days and 1.6 at 30 days, so it's not a high mortality, but it does not stop there. Like in coronary artery disease, your 40-day mortality, 6 months, it goes down. So in this case, the mortality grows, and you have mortality rate at 1 year of 8.4%, which is significant. There is a 25% recurrence, and most of the recurrence occurs in the first 6 months or max 12 months. So generally, people who have syncope are asked not to drive in the first 6 months. So summarizing, syncope is still the most challenging of all diagnoses in cardiology. Neurocardiogenic syncope is commonest, but cardiogenic is the most dangerous, so it should not be missed. And we must follow algorithms, because why? Higher yield and they're cost effective. With this, I thank you.
Thank you, Professor Amir Hamid, for this insightful talk on syncope.